Okay. All right. Can everybody see the screen? I hope.
Yes, I can see it. Thank you.
Okay. Okay. Well, welcome everyone. My name is Aaron Twitchell. I'm the program director for End of Life Choices New York. We are a strong but small nonprofit organization whose mission is to raise awareness, to provide education, support for people who want to plan for a better end of life. And we make sure that everybody knows what their rights are when it comes to their healthcare decisions and things like that. We also advocate for the passage of medical aid in dying legislation in New York State. And that legislation is in I think it's in the assembly right now, and we're hopeful that the legislation will pass, but we don't know. Last year we were close, and it didn't end up happening. But we also focus on a lot of education workshops like this for organizations and agencies and their constituents. And then finally, I also provide direct support to people who just call needing some guidance on their healthcare choices. So when folks call, this is who they're getting. You can see I have a little bit of a background in spirituality and chaplaincy. That's kind of my vocation and my training. I don't really bring all of this to bear as the program director for End of Life Choices New York. We're obviously not a religious organization, but I do a lot of work with people in spirituality in general. And so I'm able to kind of guide those conversations as well when folks reach out. In this presentation, we're going to discuss something called advanced care planning, which kind of encompasses all of the things you see on the screen right now. There are some forms involved in advanced care planning that you can fill out and have signed so that you are prepared in the event that you cannot communicate for yourself when it comes to your healthcare treatment. We'll talk a little bit about how to talk about those wishes and values with your loved ones, because filling out the forms is only one part. Having those conversations with people is equally as important. We'll talk a little bit about palliative care and hospice and just make sure that we get the basics out. Unfortunately, New York State is not really on the hospice train, if you will. New York State has the lowest hospice utilization rate in the country. It's under 30%, meaning that I think it's something like 24% of people in New York who would benefit from hospice actually do it. And that's compared to 50, 60% as a national average. We want people who are eligible for hospice and who would benefit from hospice and palliative care to take advantage of those services. We believe strongly in them. I believe strongly in them because it gives you the best chance to have a good and peaceful death, sometimes on your own terms. And so we'll talk a little bit about that. I'm always open for questions. I can't really see the chat, so if the other co-host, if somebody has a question that they're typing in the chat and it's worth, just kind of saying, hey, we have a question, I'm fine with that. You can interrupt me for a question. Otherwise, we'll save a couple of minutes at the end for questions. So I mentioned advanced care planning. It's a process during which a person considers and then shares their wishes and values to inform their future healthcare. This is especially important when that person, you all, me, anyone, can no longer communicate for themselves. And the reason why that's so important is because if you are conscious and alert and awake and oriented and you have what's called capacity, then you can always direct your own healthcare. You can always decline treatment. You can say what does and does not go in your body. And so advanced care planning really comes into focus when you lose that ability for whatever reason. And that, for whatever reason, is actually pretty important because a lot of times we think of this as something that we do when we get older, but there's lots of circumstances in which a younger person would no longer be able to communicate themselves. Things like just going in for a surgery, a routine procedure, and maybe there's a complication. And so maybe you spend a little bit of time unconscious. We never know. And so that's why we advocate for anybody over the age of 18 to begin advanced care planning so that they can start to think about what it is they would want in the event that they can't make their own decisions. I mentioned earlier that having conversations with your people, and when I say your people, let me just say, because I'll kind of use that phrase throughout the workshop today. When I say your people, I mean anybody that you consider to be kind of in that inner circle, friends, family, neighbors, coworkers, people in your building, people at the community center, whoever it is that you think of when you think of the people that you would talk about your healthcare wishes to. And so I mentioned the importance of conversations. So on the slide that you can see right here are just some questions and conversation starters that we say are a great way to start having these conversations. And let me just explain a couple of these because, at first thought, it may seem that what do these questions have to do with healthcare or advanced care planning? And the reason why these are so important, there are a couple of reasons. Number one, it helps get the conversation started. To start a conversation about something difficult like death and dying, sometimes it helps to kind of back up a little bit and just start those conversations with your people. Start them about things that are pleasant to talk about. So, what makes a good day for you? Like when you think of having a good day, what does that mean? Because that's different for everyone. What are you most proud of? Your accomplishments or your abilities? What are you proud of that you are able to do? What matters to you most in life? And so the reason why these are important starters is because depending on your health condition later on, that's going to be a way for you to determine what your quality of life looks like. And so as you start to think about what treatments you would want or what treatments you don't want, or the course of your illness, you're gonna think about your quality of life. So for example, if I say what makes a good day for me is to go out into the yard and to garden, maybe walk my dogs, that's a lot of movement. That takes getting outside. It takes physical ability and mental capacity. And so if that makes a good day for me, then I need to think about what if this treatment or this procedure is going to make it so I can't do that anymore, and that's going to affect me in a certain way. And so I need to make sure that I'm thinking about what it is that makes me happy. So for example, one more example, if the doctors tell me that I could have 3 months left during which I could do all those things that I love, or I could have 6 months left, and for most of that, I probably won't be able to do anything. So that's a decision that I'm going to have to make then, based on what it is that's important to me. And then the last question that I just want to lift up is who is your strongest advocate? So the reason we ask about this question is because for something like a healthcare proxy, which I'll get into in a few minutes, a healthcare proxy is somebody that you name. It's a person that you name that can speak for you when you cannot speak for yourself. And we use the word advocate here because, if you think of your loved ones, your people, and you think of somebody who really loves you a lot, that's great. But is that person going to be able to stand up in the hospital and advocate for you? I'm lucky. My healthcare proxy is my wife, who I think loves me a lot, but she also is a wonderful advocate, and she's not somebody who's going to be pushed around in a facility or by medical staff. She's going to stand up for me and what my wishes and values are. Other people might not be so good at that, and so that's the kind of thing that you want to balance when you think of your healthcare proxy, is somebody who has your best interests in mind and can also communicate those interests when it matters. The core parts of advanced care planning, like I mentioned, is decide who will speak for you, who will be that proxy. The healthcare proxy is a person, and then it's a form that you fill out naming that person as your agent. Then you want to identify what your core wishes and values are, what you would want your medical treatments to entail, what you want to guide the doctors. Do you want them to pursue all curative treatment, do whatever they can, or do you want them to be guided by something like comfort? Then once you've had a chance to think about those things, you want to share what you concluded with your people, especially, of course, your healthcare proxy. So if you have somebody who is going to serve as your agent, then you want to make sure that they know what your wishes are. Once you've been able to have those conversations with someone, then you document them in the forms that we'll get to, and then you revise those forms as you need, and you revise those conversations as needed. And so that is what begins the process. So we're going to go through a few forms that collectively are called advanced directives. Let me just make sure that I pause briefly here just to make sure that we're all on the same page with vocabulary. So all of what we're talking about today is called advanced care planning. That term, advanced care planning, is like the umbrella that covers lots of different aspects. One aspect of advanced care planning are the forms. And so those are called advanced directives because they direct your healthcare when the time comes. So what are advanced directives? They're forms that describe your medical wishes, including things like treatments, procedures, surgeries, if you develop dementia or Alzheimer's. And these forms dictate what you want and what you do not want. They protect your right to have your healthcare wishes respected, especially if you lose the ability to communicate that yourself. Everybody should have an advanced directive as long as they're 18 and over. It's like I mentioned a few minutes ago, it's not just for the elderly or the very sick. It's for anyone over 18 who wants to be prepared. And so it's it's paperwork to sort of support those conversations that you're going to have with your people. The first form that we're going to go over is the healthcare proxy form. So I mentioned that, thinking of someone who will advocate for you, that person is themselves your proxy. And sometimes that person is called a healthcare agent. Those terms are interchangeable. So healthcare agent, healthcare proxy is the actual individual. And this is the form that accompanies the individual that names them as your agent. Now, we strongly recommend that everybody over the age of 18 fills out a healthcare proxy form and just get it over with. Have that conversation with the person and then fill the form out so that it is done. Again, because we never know what's going to happen. And you want to make sure that that person is named and documented. And when you name that person, there are a couple of things of important things that go into the healthcare proxy form. First of all, it's 2 pages. It's available on the New York State Department of Health website. It's actually not a bad website if you've never visited it. They have a lot of resources on there. It's available in several different languages, and so you can just download it and then fill it out. Whoever you name as your agent needs to be at least 18, and themselves needs to have mental capacity to sign documents like this. And then you need to have 2 witnesses that sign the proxy. And notice it says that the witnesses must be somebody other than the proxy that you are naming. So to review, that means that there are 4 people involved in your healthcare proxy form. There's you, who's filling the form out. There's the person that you are naming as your proxy. And then there are 2 witnesses that are going to sign to attest that you are who you say you are. I also want to make sure I emphasize that the form does not need to be signed by an attorney, and it does not need to be notarized. And that's a purposeful decision because access to these rights and these forms is very important. And the government is interested in everybody being able to have a healthcare proxy, regardless of their ability to pay for things like attorneys and notaries. So that's the main reason why these forms don't require an attorney or a notary. If you don't have a healthcare proxy, one common question is, what happens if I don't have a proxy and I cannot communicate for myself? So just imagine that you are in the hospital or in a facility, you've been in an accident, or you've declined rapidly, because of an illness or whatever the case, and you do not have a healthcare proxy. What's going to happen? How are these decisions going to be made? And this slide right here goes through the order according to New York state law. If somebody has a court-appointed guardian, then that person speaks for the patient no matter what. That's always number one. There's lots of, it's not common, but there are lots of reasons why somebody might have a guardian. And so if they do have a court-appointed guardian, then that person is automatically who makes these decisions for you. For most of us, we don't have a court-appointed guardian. If we have a spouse or a domestic partner, then that person is going to be asked by the medical team, do you know what, and they're going to go to your spouse or your partner, they're going to say, do you know what Aaron wants in terms of, these procedures? If I didn't name my spouse or partner as my proxy because I didn't have one, then automatically they're the ones that are going to be asked. If I don't have a spouse or partner, or they've died or whatever, then they're going to look to see if I have any children that are at least 18. Can they make these decisions for me? And if I don't have that, on down the list. You'll notice number 6, it says close friend, and that is true. If a medical team can locate a close friend of a non-communicative patient, then they will, and they will ask that friend, what do you think this person would want? And if none of these are available, then, and actually it's a pretty common occurrence that you see down there, it says the medical facility makes the decisions. Rare courts getting involved is uncommon, but if necessary, they will. Usually it's just the medical team that will decide. In most cases, if the medical team does decide the course of treatment, it's going to be pretty aggressive, because usually medical teams and doctors, they want to cure the patient. And so that's what they're going to focus on. When you have a conversation with your healthcare proxy, when you choose, like I said, they are going to have all the decision-making power as if you yourself were making these decisions. So that's why we say, in addition to the forms, that's why we say how important it is to have these conversations. Because if your healthcare proxy has these documents and they're filled out and signed with your healthcare wishes spelled out, and they also have had conversations with you, those two things together are going to give you the best chance to have your medical wishes, adhered to. So we want to make sure that people are both filling out the form and talking to their healthcare proxy and making sure they know what it is you want. And so what kinds of things would you document, and what kinds of conversations would you have? And, we kind of covered this already. So you would say to your proxy, if I become terminally ill, I want to make sure that treatments focus on either things like curing my illness or comfort, mobility, for example. Maybe you say that I want my treatments to focus on preserving my autonomy. That's an important one for people. So things like feeding myself or using the restroom on my own, those could be important things. And so in other words, if a course of treatment is going to limit my ability to do those things, then I might not want those. Another way to say it is, what matters to me the most when making these medical decisions is, and then you fill that in. And then of course, like we saw on the other slide, you could say, to me, having a good quality of life means A, B, and C. And so, if I'm not able to do that, then I don't consider that to be a high quality of life. So we will see examples of treatments as we continue on with the other forms, but just some examples of treatments that are going to come up for people are things like artificial respiration, nutrition, and hydration. So do you want a machine breathing for you, or any kind of oxygen supplement? Do you want nutrition coming through a feeding tube or whatever? And do you want fluids being given to you through IV? I mentioned being able to feed oneself. That's an important consideration that many people make. And so that's something that people think about. Do I want to be, if I'm in a condition where somebody has to feed me, how am I going to feel about that? CPR is a big one. If I'm found to be unconscious, or my heart has stopped, or I've stopped breathing, do I want to be brought back, or do I want them to attempt artificial resuscitation? And even antibiotics is something that people need to consider, particularly depending on their medical situation and the conditions that they have. I have a background in hospice, and so antibiotics are rarely used in hospice because why? This person has accepted the course of their life and all of that, and so they don't want to worry about taking antibiotics. But I should say, sometimes antibiotics are indicated for comfort. And so that's a conversation that you can have with your medical team. Something like a urinary tract infection or things like that. So that's an example of, this is another example of treatments that people will need to decide on. A living will goes into more detail than a healthcare proxy. A living will is a document that sometimes is created with the assistance of a lawyer. and it outlines specifically the treatments that you would or would not want. If somebody has a living will, or it's also sometimes called an advance directive, if somebody has a living will, it is filled out and the doctor has no reason to be suspicious of the signature or of the wishes that are outlined, then that doctor and that medical team are required by law to honor what is in that living will. In the absence of, as you can see, it's quoted on the slide, clear and convincing evidence that it, for some reason, does not actually reflect the wishes of the patient. That's not a common occurrence, but if you can put yourself in the shoes of a doctor and you're reading a living will and it outlines the treatments, you do want to make sure that there's no reason to believe that this was somehow fabricated or edited, or that it was done under coercion, or things like that. Again, that's not a common thing, but that is something that doctors and medical teams do try to ensure that they can trust the document. Also, why it's a good idea to have the conversations, because then your healthcare proxy can say, I agree with what this living will says. This patient, not only did they write it down in this living will, but they also told me, and the document and I agree that this is what the patient wants. And so it's a very valuable document to have, because it goes into detail, like I said, about certain treatments, and allows you to think clearly about those, and then to dictate that to the medical team that will be treating you. I've got two more, and then I'll pause and see if there are any questions. A DNR, sometimes called an out of hospital or non-hospital order, basically says, I do not want to be artificially resuscitated. So again, for example, if emergency personnel find you and you've stopped breathing or your heart has stopped beating, if you have a DNR, then they will not attempt to resuscitate you. You'll notice on this form, though, that it requires the signature of a healthcare professional. In New York State, as you can see, that healthcare professional can be either a doctor, a nurse practitioner, or a physician assistant. The reason that you need to have your medical provider sign this is because they want to make sure that you know what you are signing. For example, if a young person who's relatively healthy comes in and says, I want you to sign this do not resuscitate order, that doctor is going to have a couple of questions. Why don't you want a CPR? Somebody like you who's young and healthy and is strong and not frail, you don't have any terminal illness or anything like that. And so those kinds of people, that's exactly who CPR is designed for, and that's who benefits from it most greatly. And somebody who's young and strong, when they receive CPR and are revived, they had the best chance to go on and live a normal life. And so that doctor is going to want to know, why do you, young and healthy person, why don't you want CPR? And they just want to have that conversation to make sure that they're covering their bases with someone's mental health. But for people who are either older, frail, weakened by disease or whatever, CPR can, of course, be a violent and painful procedure. And also, there's a lot less of a chance that even if that person is revived, that they're going to turn around and lead the life that they were living before. And so all of this is something that your doctor can explain to you when you ask for their signature on this DNR form. So once your healthcare provider signs your DNR, then you want to hand that to whoever is going to make sense to have it. Whoever is likely to be in the know when something like this happens. And so your primary care doctor, your oncologist, your neurologist, the facility that you live in, or your neighbor, anybody that, for whom there is a decent chance that they will be around, and that you just feel like needs to know your wishes, that you do not want to be to receive CPR. So that's who you would give it to. A lot of people will make sure that it's in their homes, and in a prominent place for everybody to see. If you don't want to, advertise that to everyone, just make sure that everybody knows where it is, so that if something does happen, that they can just pull it out and they have it in their possession. Medical orders for life-sustaining treatment is the last document that we're going to go through. This is similar to a living will, but there are a couple of differences. Let me just go to this next one real fast. I'll go back to the other one in a second. Some of the differences are that a most is usually reserved for somebody who is seriously ill and in general has about 18 months or less to live. And they, such a person, because they know their prognosis and they've had this conversation with their doctor, they say, I'm done with the treatments. I don't want any more life-sustaining treatments. I want to be as comfortable and active as I can for my remaining time. But then I've accepted, my fate. And so I don't want to go to the doctors or go to the hospital and have, be intubated and have all these procedures. It's very common for people who live in, for example, long-term care facilities. And what the most form is it is similar to a living will, except that, as you can see, it is an actual medical order. And it is the same kind of medical order as any other procedure or doctor's orders that they have on file for you. And it goes into detail for a lot of these treatments. And so as you can see on the screen here, let me just direct your attention to, actually, let's just go to right under where it says section E, and it says life-sustaining treatment may be ordered for a trial period to determine if there is benefit to the patient. If a life-sustaining treatment is started, but it turns out not to be helpful, then I, the patient, say that the treatment can be stopped. So this is important because you're setting guidelines for your treatment. And believe it or not, it is more common than we want to think that, that a doctor orders a course of treatment, it's not working, and they just keep going. And so this tells the medical staff that you don't want that to happen. Under the next section, it says treatment guidelines. And this sets the tone for kind of the goals, the overall goals of your treatment. And so you can see that there is kind of a spectrum. The first box says comfort measures only. So I just want to be kept comfortable. That's it. Or you can go, a little bit more down the line and say, yes, I do consent to some treatments, some interventions, but I want them to be limited and I don't want them to be too invasive. So for example, it says I can receive medication by mouth or through a vein. Yes, you can monitor my heart, but something like an intubation is not something that that this patient would want. Or you can check the last box, no limitations on medical treatments. This patient will receive all needed treatments. And as an organization, let me just say that if that's what somebody wants, then we want them to have that. Our goal is, we don't have an agenda in terms of healthcare. So we don't think that people should check the first box at all. I work with plenty of folks who check the last box and they say, I know that my time is short, but I want them to do it all if I get sick. And so that is your right. And then the rest of the form just goes into several other treatments that you can discuss with your people that you can think about and decide if you would want. So at the bottom, for example, it's the section about feeding tubes and IVs and things like that. And so this is your chance to choose or decline these specific treatments. And then, of course, your doctor signs the most, and that becomes part of your medical record. The last thing I want to say about this is that it does not take the place of your healthcare proxy. So just like a living will, this is a document that is good to have depending on who you are in your situation. It is best when this document works together with your person, your proxy, the real live human being who can vouch and say, yes, this form is correct based on my conversations with this person. I'm not going to go through the dementia directive in too much depth because this is an area that's changing a lot in end-of-life care because what we're finding out is that what the courts haven't really caught up to this yet. And what's happening is that somebody fills out forms when they are of sound mind, and then later on, their dementia advances and they're no longer of sound mind. And the doctors are saying, do we follow the forms that they that they filled out, 3 years ago, or do I treat the person that's in front of me who can't make these decisions right now? And so that's something that's really being worked out in both, bioethics fields and also in law. But having said all of that, the dementia directive is something that we developed that specifically addresses the situation that I just described. And the intent is that, uh, if for example, that some kind of dementia related disease runs in your family, or you are early on in a diagnosis, then this is why this form was developed, because what's going to happen, and you want to be prepared for that. And so you want to say, when this time comes, here's what I want and here's what I don't want. This whole thing is meant to avoid situations in which somebody is minimally conscious, or definitely not alert and oriented, but just kind of lying there in a facility. And I've seen this happen many, many times, and they're being kept alive by artificial nutrition and IV fluids. I worked on one case a couple of years ago where this person had been living this way for 14 years, and he would develop a bed sore. They would send him to get treated, and when the bed sore healed, they would send him back, and he just went like that for a long time. And we were able to help the family advocate for him and themselves, and it was a good resolution. But that's what people are trying to avoid, because that's not a quality of life that aligns with most people's values. When you have filled out all of these forms, collectively called advanced directives, all of them, you want to give them to, again, anybody in your circles, your people, certainly your doctors. Of course, the MOLST form, the medical orders for life-sustaining treatments, that's going to be kept on file at your doctor's office. If you have a family attorney, of course, you can give it to them, and anybody who might be involved in your healthcare decisions. You want to make sure that it's easily accessible. A lot of folks are storing them digitally on their devices or on their computers, and make sure that it's easily, like the hard copies are also easily accessible. And we also say that you should review your documents about every 10 years if nothing has happened. And if that's you, first of all, I think you should write a book, because if nothing significant has happened in 10 years, then I want to know how you do it. If you have some major life events, somebody gets married, or there's a new birth, or a divorce, or a death, whatever, we always suggest that folks take that opportunity to review their documents and make sure that their wishes and values are still the same, because people do change over time. So I'm going to stop my sharing here for a second and just pause and see if there are any questions either in the chat or that somebody wants to say. So, okay, I actually don't see any questions. Are there any questions from folks on the call? Okay, I will take that as evidence of my effectiveness. Let's see. Okay, we're going to move into another section of advanced care planning, which involves understanding palliative care and hospice. These are two fields of medicine that are often misunderstood. And so part of our mission at End of Life Choices New York is to educate folks on what palliative care is and what hospice is. Let's start with palliative care. So palliative care is a medical specialty. So just like oncology, neurology, it is a medical specialty, and it is for people who have serious illnesses or are like post-injury, post-op, and their ailment is significantly impacting their life, their ability to enjoy life. And that could be because of pain or discomfort or a change in your abilities. Palliative care focuses on the patient's comfort and pain management. And that's really all they're concerned about. So for example, let's say that you are a cancer patient and you have a team of doctors. One of those doctors is an oncologist, and that oncologist is focused on curing your cancer. And that is their number one goal. And you might also have, let's say, a kidney doctor who's monitoring your kidney function. Now, all of those doctors are going to be concerned about your well-being and your pain and your discomfort, but it's not their primary goal and their primary focus. A palliative care doctor and a palliative care team, their only goal is to mitigate the pain and mitigate the effects of the treatments that you're receiving, mitigate your discomfort. And so it is palliative care is something that you can be involved in throughout the course of your illness or treatment. And you can receive that attention and that care. And you'll have access to a lot of different professionals. So, for example, if I help folks get a palliative care consult, and I say these are all the things that you are going to get, and that these are all the ways that you're going to benefit from having a palliative care team. Any physical symptoms that you're experiencing, so pain or loss of movement or coordination, things like that. Anxiety and depression is a big one, and you'll have access to mental health providers. Any social issues like any kind of caregiving situation, or if there's something going on in your building or in your neighborhood that is somehow impacting the quality of your life, then they'll help you look at that. They'll help you work with your family. If there's anything to be done there. Spiritual concerns, if you want to talk about your experience, in treatment, or, your prognosis or whatever, there are chaplains available with palliative care teams. And then planning and resources, palliative care social workers and nurses to help, just plan the course of your treatment and make sure that you're covering all the bases for your quality of life. And so these are all the professionals that you have access to. I'll just lift up a couple of them. For example, the mental health providers down here, it says psychologists, art therapists, and music therapists. So I'm a big fan of these. I'm a big fan of music therapists and art therapists. Such an underutilized benefit for people. People will come and they will play music and help you heal and cope using music. It's wonderful. And same with art. So you'll have access to all of these professionals on a palliative care team. Palliative care teams are billed the same as any other specialist according to your insurance. Medicaid and Medicare plans typically do cover palliative care. In my experience, it says, though, it may not be 100%. It usually is pretty close. So that's a good thing. And the reason is, actually, this is a good plug for palliative care because insurance companies realize the value of palliative care. People who are in palliative care have far better outcomes than people who don't utilize the services. And so it actually is cheaper for an insurance company to cover palliative care at 100%, because when they don't do that, it deters people from using them. And then it actually costs more when we look at the totality of their care. It says not all medical facilities have a palliative care department, and that's true. But in my experience, I want to say 9 out of 10 facilities and hospitals in New York City do have palliative care. And same with some of the larger cities around the state. When we get into the rural areas, unfortunately, that's where we have less access to palliative care, which is unfortunate. You can always request a referral. And so want to make sure I emphasize that last bullet point. You can request a referral, or you can contact them directly. So I encourage anyone who finds themselves either in the midst of an illness where there's a lot of pain or discomfort to get a palliative care consult. Ask for a referral, and if the facility is not as cooperative, find a way to reach out to a palliative care team yourself, or ask somebody to do it on your behalf. We do that. So you can reach out to us or some other organization and ask for help in coordinating that care. Hospice is related to palliative care. If you think of palliative care like a large circle, hospice is within that circle, but it has its own special requirements and eligibility criteria. It is considered a type of palliative care, but it is for people who have been given a prognosis of 6 months or less, sometimes 9 months, but almost always 6 months. If somebody's illness is not responding to treatment, if we've tried lots of treatments, if something new has developed and that's complicating the treatment that you were receiving, whatever the case is, at some point, you or your family, your doctors, need to figure out, what you want to do. And this goes back to kind of the beginning of advanced care planning, because at some point you may decide that you're done with the treatments and you just want to make sure that you have the best 4 or 5 months that you can. And that includes, I want to make sure I point out too, it's not just how you yourself are feeling inside, but a lot of times in that 4 or 5 months, that gives you quality time to spend with your people. And so, you don't have to worry about going in for treatment. You don't have to worry about all these things that impede your ability to interact and to spend time with your loved ones. And so that's one of the main reasons that people choose hospice, is because they say, I might be able to live for 8 months if I continue treatment, but in that 8 months, since I'm continuing this treatment, it's really going to make it hard for me to enjoy my life and spend time with my people. So I'd rather do, I understand if I stop treatment that gives me 5 or 6 months, but it's going to be a way better quality of time. And so that's kind of the thinking that goes into to reaching out to a hospice. Hospice, like I said, is a form of palliative care. It focuses exclusively on your comfort and your pain management and your quality of life. There's no more curative treatments, and so that's something that people obviously need to keep in mind when they're considering hospice. So just using the oncology example again, that means in most cases it means no more chemotherapy, no more radiation, therapy or any of that. That's all stopped. And the patient just says, whatever you give me, make sure it's for my pain and my quality of life. It's not a place that we go. About 85% of hospice patients receive the care at home, and that's something that surprises a lot of people. But as long as it's possible, you will receive your hospice care at home. And the hospice team, the hospice agency, will train anyone around you anyone who lives there or who will be coming in to help care for you. They will train them to do some of the basic care, even administering certain medications. Otherwise, the hospice team comes with people that come in and care for you during that time. There are hospice facilities around New York, and the hospitals usually have at least a few rooms that are dedicated for hospice. And that's because, sometimes even to keep somebody comfortable requires more resources than somebody might have at home. And so there are facilities and hospitals that can accommodate hospice patients. But again, almost everyone, if they could choose, they would choose to die at home. Not everyone, but most everyone. So this is just a list of the things that hospice offers, the benefits that you get, nursing visits, all kinds of patient support. I want to draw your attention to the fourth bullet point here, grief and bereavement support for up to a year. It's actually longer. The average is 13 months. So for 13 months after the patient dies, family is going to be supported by that hospice agency. They're going to get phone calls. They're going to get cards. They're going to get checked on by the hospice. Similar to palliative care, all of these professionals, physical therapists, occupational therapy, and speech are all things that are available to hospice patients. And if you think about it, this is very important because part of ensuring the highest quality of life is, being able to use your hands and your feet as long as possible, being able to lift your head up for as long as possible and feed yourself, to get around your home for as long as possible. I still see hospice patients on an as needed basis. And I have some hospice patients that have been on service for 10 months or a year. Because when they came on, they were still mobile and they were still up and about. Yes, they had a prognosis of 6 months or less. But because hospice is so good, these people were walking around their homes for a good several months. And that's because of the occupational and speech therapy that they were receiving. So it really does help people make the most of that time. Pet therapy is another one that I love, and of course, music therapy is available for hospice patients. You can see this list is similar to palliative care. There are chaplains. There are other psychosocial support professionals that are available. You get all the equipment you need, and your family and caregivers are trained on using that equipment. And even your caregivers get support. So respite care is a required part of hospice. And so your caregivers will be able to take a break, and hospice will provide somebody to come in and stay 24/7. This is an important time to mention that hospice care is not 24/7. So, in my experience, this is what happens. The hospice comes in and says, here's how often we can come to the house to give medicine or whatever, but it's not 24 hours a day. And so what happens is, either family, friends, caregivers, whoever else lives at the house is going to supplement that care, or people develop a schedule where they come in and help care for the patient when the hospice cannot. Another option, and for people with resources, is to hire private aides and private nursing to come in and supplement that time. A lot of times overnight, is a big one for families, is that if they can afford it, then yeah, they're going to have somebody come in overnight and to stay with the loved one. If none of those are possible, it is possible for somebody, for example, who lives alone and does not have anybody that's close to them to help with caregiving. It is possible for that person to receive hospice, and I've been learning a lot more about that, because it was hard for me to kind of wrap my head around, somebody being on hospice at home but not having anybody around them. It's a lot more common than I wish were true, but so hospice agencies are adapting, and so there are ways to to make it possible still, even if that patient doesn't have a caregiver at all. And finally, you can see here homemaking and home health aid assistance. Yes, the hospice agency will clean your kitchen for you. They will help organize your home so that it is most accessible. They'll help you with dietary and nutritional advice to make sure that you are receiving good food and good nutrition during your time on hospice. Just got a couple of slides here, and then we will wrap up, and if there are any questions, we can have those. So one important difference between hospice and palliative care is that hospice is a Medicare program. It's under Medicare. It's paid through, in New York, it's paid through New York Medicaid. And it is covered 100%. So regardless of your ability to pay, you will receive hospice care. And then also anyone can make that referral. So just like palliative care, people can just ask for it. So this is a very common piece of advice that I end up giving to people, is just ask for the hospice consult. And the reason I say that is that a lot of people assume that they're not eligible for hospice because they don't have, let's say, they don't have terminal cancer, or they don't have end stage COPD. They don't have one of these big diagnoses that are more well known in terms of having a terminal course. But I always say, let the hospice decide that. There are other diagnoses that meet hospice criteria. And so I always encourage folks to ask their primary care doctor or whoever if they'll write a referral for a hospice agency. And if they won't, just call the hospice directly. You can always call the hospice agency directly and say, I'd like to talk to somebody about my loved one or about me. Can you help me decide if hospice is right for me? So as a whole, all of what we did in the workshop is considered, advanced care planning. The conversations, the documents, knowing about palliative care and hospice and those resources is the planning for end of life and for end of life care. And sharing those wishes and values with your people, and then having those advanced directives filled out and signed. All right. So are there any questions? I'm looking at the chat. If a couple, husband and wife, have different wishes, are two separate healthcare proxies needed? Let's see. The easiest way to answer that is that yes, every individual must have their own healthcare proxy. if you're asking like, what if the person I name as my healthcare proxy disagrees with my wishes, then that person should not be your healthcare proxy, is what I would say. You know, you have to make sure that your healthcare proxy is going to advocate for your wishes and values. And so it's important that that person is fully on board, you know, with it. And also you can't have, you can have a healthcare proxy, you can name an alternate. Actually, I think you can name up to 2 alternates. And so in that sense, you can have more than one on the form, but there's a primary that is going to serve as your agent unless that person's not available. Does that answer the question? All right. Any other questions? The last slide I have is just to let everybody know about our annual lecture coming up. It's free, of course, but I'm really excited for this. It's virtual, so it's on Zoom. And this is who we have speaking. We have Thaddeus Pope, who is probably the foremost bioethicist and legal scholar in America when it comes to end-of-life issues. And he's going to talk about, you know, kind of the basics of bioethics when it comes to end of life, things like medical aid and dying and, you know, other considerations. But then we're also going to have the daughter of a woman who elected to do medical aid and dying in New Jersey earlier this year. And that family, the woman who chose medical aid and dying, and all of her friends and family, they were all featured on a CBS News special, you know, where they interviewed them and were there on the day. They didn't film her passing, of course, but a super intimate look at that choice and the dynamics. And the daughter is going to be a part of this lecture, and so she's going to share from her perspective, you know, what that was like and why medical aid and dying in particular is so important to her. And so I just want to invite everyone there. We do ask that you register just so we can keep track of folks. You can scan the QR code. You can also head to our website, eolcny.org, and under events, you know, you can click on that, and then you'll get the Zoom information. So I want to thank you all for joining us today. Like I said, I do these workshops for lots of different groups and organizations and people. So if you know someone or a group that would benefit from a workshop like this, please don't hesitate to reach out to me.
Hi, Aaron. I do have a question here.
Yeah.
So, as a staff from the case management agency, we usually have clients come to us regarding questions on end of life choices or planning. So, do you think in the future we could probably refer the clients to you guys for a consultation or
Oh,
further?
I think you should be doing that now. Yeah, so that's a pretty common, that's how a lot of this happens, you know, is that you know, these places like University Settlement and other community agencies and groups, you know, they do a lot in their communities. But like you said, sometimes, you know, somebody comes with a need or a question, and it's actually something that they don't, you know, have a lot of resources or information for, and so then you refer that person. And yes, that's how we get a lot of our referrals is, hey, a client of mine, you know, has these questions, can I send them to you? Or you don't even have to reach out to me separately. You can just give them our, you know, either my email address, you know, or send them to our website, and they can reach out on their own. So either, you know, however they get the handoff is fine. But that's what we spend a lot of our time doing is helping folks with questions like that.
All right, thank you so much. So,
Mm-hmm.
if we are going to refer clients to you, so we just email the education email address.
So for workshops, you would email education. I would
Uh-huh.
say for the situation you're describing, you can email me, and my email address is Aaron, Aaron, and then the rest of the email is the same. But either one, actually, I mean, people who write to education, those emails come to me. So either one works. And yeah, they can just email me and say, here's what I need help with, and you know, that's what I spend a lot of my time doing throughout the week.
Yeah, sure. Thank you so much.
Mm-hmm.
And thank you everyone for joining today's workshop. And thank you, Aaron, for presenting today. And I'll see you again in May.
Thank you, everyone.
Thank you. Have a good one.
Bye-bye.